Welcome back to MLT 110. In today's lecture, we'll be covering the basics of clinical chemistry. We need to cover a few definitions in relation to clinical chemistry. The first is postprandial. This is when a specimen is collected directly after eating. Next, we need to discuss the difference between qualitative testing and quantitative testing. Qualitative testing is when you report the presence or absence of a substance, and this is a lot of times just reporting out a positive or negative result. And a lot of times this is associated with a color change in testing. So is the color present or not present, or is there a change in color from the beginning of the test to the end of the test to indicate a positive result? In quantitative testing, this is measuring the amount of substance present. So usually there's a numerical result related with a quantitative test. You're getting the exact quantity or the amount of a substance present. So this is usually a number result. This slide is just giving you some basic general information about clinical chemistry. Clinical chemistry is a branch of the laboratory that uses chemical analysis to study the levels of various body constitutes during health and disease. So basically, we test for different chemical elements within the body to help treat and diagnose disease. We can perform chemical analysis on all kinds of different samples from the body, but of course our most common sample that we test on is the blood. We can also test on urine samples or different body fluids such as spinal fluid or abdominal fluid. Physicians or doctors use the results from these chemical tests done in the laboratory to help diagnose disease or begin treatments for different conditions, or also to help follow the progress of a diagnosis of a disease. The results of a chemical test can let the doctors or physicians know are the treatments that or the treatment plans that they have patients on working or not working based on the results that are given. The next thing we should discuss is the difference between routine testing and special testing. Routine testing are tests that are done pretty frequently within the laboratory, things that are probably done on a daily basis. This could be things like your liver panels, your cardiac panels, sodium levels, glucose levels, things like that. Special testing would be things that are not done every day. These may even be send-outs. It may be tests that the hospital or your laboratory don't even regularly keep reagents for. They may be only done weekly, monthly, or just on a very rare occasion. Okay, up next is a reference range, or what's normal for a test. All clinical chemistry tests have a reference range. So an example of a reference range would be our glucose. Our glucose reference range would be, or normal range for glucose would be between 70 and 100 milligrams per deciliter. So anything below 70 would be considered abnormal on the low side, and anything above 100 would be considered abnormal on the high side for glucose. Normal ranges are usually determined by measuring a portion of the general population in order to establish a reference range. It's usually looking at least 100 individuals. Other things to consider when you're trying to come up with a reference range is a patient's age, their sex, their size, and their physical condition, because all reference ranges may not be the same for every patient, especially within different genders and different age groups. Some of the most important analytes that we measure within clinical chemistry are our electrolytes. These are minerals in the blood and other body fluids that carry an electrical charge, and these affect how your body functions. There are 4 ions or electrolytes that have a great impact on the hydration, the acid-base or pH balance of the body, and also the heart and muscle function of the body. We're going to discuss all 4, but let's start off with sodium. Sodium is an extracellular cation with the highest serum concentration. So let's break that down and discuss exactly what an extracellular cation is. Extracellular meaning outside the cell, and cation meaning it has a positive charge. The next electrolyte is potassium. Potassium is an intracellular cation. It is the most abundant within the cells. Okay, so it is the opposite of extracellular, like sodium. It's intracellular. So intra means inside the cell, but it's still a cation, so it's a positive charge. So the 2 major cations in the body are your sodium and your potassium. The next 2 are going to be your anions. These are going to have a negative charge. Okay, the first one is chloride. This is an extracellular anion. So extracellular meaning outside the cell, anion meaning negative charge. This is the major anion of the body, chloride. The last one is carbon dioxide. You'll also hear it referred to as bicarbonate. This is an extracellular anion. Again, extracellular, outside the cell, anion, negative charge. Within clinical chemistry, we can also measure several minerals within the body, such as calcium, phosphorus, and iron. These minerals are necessary for good health and must be in balance for proper body function. Calcium is the most abundant cation in the entire body. It helps with things like strong bones and teeth. It also helps with heart function, nerve function. It also helps with other body systems to work properly. It also helps with blood coagulation, which is blood clotting. Low levels of calcium, which is known as hypocalcemia, can be life-threatening. Phosphorus is up next. It's the second most abundant cation, and it worked with calcium in the body. And you'll find approximately about 80% of your phosphorus in your bones. And phosphorus is an essential mineral for growth of the body and repairing of body tissues and cells. The last one on this slide is iron. Iron is a very important component of hemoglobin, and you'll find your hemoglobin within your red blood cells of the body. Iron helps carry oxygen throughout the body, and iron is absorbed through dietary sources or things that we eat, and iron is conserved by the body. These next few slides are going to cover some clinical chemistry panels or profiles that are pretty common or routine to the chemistry section in the laboratory. A chemistry profile or panel is used to screen for the function of major organ systems of the body. Okay, up first is the kidney or the renal function panel, and this panel is used to see how well the renal organs are functioning in the body. Remember, in the urinalysis section, we learned that the kidneys help eliminate waste products from the body, or they help filter the blood. So these tests are set up to determine, are those renal organs working properly. So the tests that are included in this panel are the creatinine test, the BUN test, or the blood urea nitrogen test, the glucose test, and the GFR test, which is the glomerular filtration rate. Another common test that is done in clinical chemistry is the liver or hepatic panel. These tests include the total protein test, the albumin test, bilirubin, and liver enzymes. The liver enzymes include ALT, AST, ALP, the GGT, and the LD. And these tests are all assessing liver function. The last one on this slide is the cardiac panel. The cardiac panel is assessing the heart function, and tests include the CK, which is the creatinine kinase, the troponin, or the BNP, or the high sensitivity CRP, which is the C-reactive protein, or it also can include the homeocysteine test. The next chemistry panel we're going to talk about is the lipid panel. Anytime you hear lipids, think fats. The tests that are included in the lipid panel are the triglycerides, the total cholesterol, and then the cholesterol fractions that include the HDL, the LDL, and the VLDL. HDL is considered to be your good cholesterol, so that's the one you want to be high. The LDL is considered your bad cholesterol, so that's the one you want to be low. You can also run a thyroid panel. The thyroid panel might include tests like the T3, the T4, and the TSH, which is the thyroid stimulating hormone. In clinical chemistry, the carbohydrate test would be glucose. Glucose metabolism is regulated by insulin. Insulin is made in the pancreas. A type 1 diabetic or type 1 diabetes mellitus is also known as juvenile diabetes. This is when a person lacks insulin production. So it's very important for someone with diabetes to keep a check on their glucose level. Finally, on this slide would be the electrolyte panel. You can order these tests individually, but they can be ordered as a panel altogether. So you can order the sodium, potassium chloride, and carbon dioxide together as a panel. We talked about the liver panel can include the liver enzymes, but let's talk about the liver enzymes a little bit more in detail. Okay, liver enzymes can rise during acute liver disease, and then they can decrease during recovery of disease. First up is ALT. This is an enzyme that will be released when there is liver cell injury. It's alanine aminotransferase. The next enzyme is AST, aspartate aminotransferase. It's in most tissues, but it's mostly in the liver, cardiac, and muscle tissue. It's elevated during liver disease and myocardial infarctions. And of course, myocardial infarction is referring to a heart attack. The last liver enzyme is ALP, which is alkaline phosphatase. And ALP is widely distributed in the body, especially in the bone and liver, but it can be elevated in liver disease and in bone disease. But in children, ALP can still be elevated because of bone still growing. And most of the time in the clinical laboratory setting, you'll hear these liver enzymes just referred to as the acronyms as ALT, AST, and ALP. Okay, here are the clinical chemistry tests that are included in that cardiac panel. So let's talk about them a little bit more in detail. The first one up is the high sensitivity C-reactive protein, and this one screens for cardiovascular problems, and this just screens for non-specific inflammation. Next is the BNP, which is the B-type natriuretic peptide. This is the cardiac marker for congestive heart failure. So let's just review real quick, what is congestive heart failure? So congestive heart failure is a condition in which the heart doesn't pump as well as it should. Okay, the last one on the slide is troponin. It's the most widely used biomarker for myocardial infarctions or heart attacks, and it is specific for heart muscle. And it's the most widely used test because of two reasons. The presence of troponins in the blood indicate that there has been some muscle damage to the heart, and the levels of troponin in the blood remain elevated for a long time, up to 7 to 10 days after the episode. Now let's talk about some of those lipid and cholesterol tests a little bit more in detail. Our triglyceride test can help measure if there's an increased risk of cardiac disease. Increased levels of triglycerides can be caused by hypolipidemia. This can be so severe that sometimes our serum of our blood can even look like milk or lipemic. That means that our serum is normally a straw colored or a yellowish color, but there's so much fat in the serum of our blood that it's taken on this milky looking color because of the fat content. Or sometimes it can even have like a pinkish or a strawberry milkshake color look because of the high fat content that is in the sample. Cholesterol is another factor that we look at for increased risk of cardiovascular disease. The liver produces cholesterol, but when it's elevated, of course, it can increase your risk factors. We talked on a previous slide about the difference between your good cholesterol and your bad cholesterol. Again, your good cholesterol, the one that we want to be high, is your HDL or your high density lipoprotein. And then your bad cholesterol is your LDL or your low density lipoprotein. This is the one that if it's too high, it puts you at a higher risk of cardiac disease or cardiac risk. And then the last fraction that we would use to calculate your total cholesterol is your VLDL, and that's known as your very low density lipoprotein. Bilirubin is another test that we use in clinical chemistry to check for liver function or also gallbladder function. We can tell if there's liver failure or gallbladder dysfunction by running a bilirubin test. Sometimes we can tell or suspect that a patient might have an elevated bilirubin level by just looking at the serum in the tube before we even run the test on a sample, because the sample is what we call icteric, meaning that the serum has a dark yellow color to it, or sometimes icteric samples can even have a dark greenish color. For comparison, remember I said the serum after you spin down a blood tube in a centrifuge, the normal serum should have a light yellow or a straw color to it. A person with increased bilirubin or an elevated bilirubin would have a dark yellow serum or a greenish colored serum, and that might indicate that their bilirubin is elevated. The patient with liver failure or liver problems may also be jaundiced. They may just have a yellow look to their skin due to the bilirubin increase. So even a low level of bilirubin in a patient could be significant. Another test we run in clinical chemistry is for uric acid. Uric acid could be increased if a patient has gout, and this is when you have an accumulation of uric acid in the tissue and joints. And you may also have an increased accumulation of uric acid due to radiation or chemotherapy treatment. We mentioned this test earlier, but the test you would run to determine if your thyroid is being under or overstimulated would be your TSH or your thyroid stimulating hormone test. If it's increased or overstimulated, it would cause hypothyroidism. If it's decreased or understimulated, it would be causing hyperthyroidism. An albumin test could be ran as well. Remember, we talked earlier in the semester about albumin being a protein. Albumin might be included if you're wanting to test all the proteins in the body. It might be used if you're testing for liver disease or starvation or absorption issues within the body. This last slide is covering some of the ones we've already mentioned, but calcium, an increase in calcium would be hypercalcemia. A decrease in calcium would be hypocalcemia. The BUN, or the blood urea nitrogen test, is associated with kidney disease when it's increased, and the BUN is usually ran with your creatinine test, and it can be influenced by things like your diet, things that you eat, your hormones, and just overall kidney function. Also, your creatinine is excreted by the kidneys, and when your kidney function is impaired, your creatinine levels will be increased. So if there's a rise in the creatinine levels, it tells the doctor there's something going on and there's an impairment in kidney function. The last clinical chemistry test that we're going to talk about is the A1C. This is the blood glucose level over time. This is basically used for diabetes management. This measures or monitors long-term glucose control. So this is showing glucose, whether it's been elevated the past 2 to 3 months. Whether the normal glucose level is just looking at a specific moment in time, when we do the finger stick glucose, that's just looking at that particular moment in time, where the A1C is able to look how the patient has been doing over the last 2 or 3 months of time as far as their glucose management. This concludes this lecture on clinical chemistry for MLT 110. I hope you enjoyed this lecture and have learned a lot. We'll be learning a lot more on clinical chemistry when you get to MLT 130 within the MLT program.